Thank you, everybody, for coming. It's really an honor to present before you all, and in many ways, trying to spread some new and good information out there, but particularly to an audience that's so interested in educating themselves. Not only for yourselves, but also for others. I think there's so much misinformation about prostate cancer, so I hope that you can go out and spread some of the what's new and what's accurate about prostate cancer. That's really important. So I would hope that would be another one of the good outcomes that can come from this talk. So I work here at NYU as an oncologist and as a prostate cancer researcher as well. I spend half of my time doing research, leading the clinical trials program here for prostate cancer, developing some hopefully newer, more effective treatments and better ways of testing them also in the lab. Today I wanted to talk a little bit higher level about where I think what's new, and I don't know if it's really relevant to everybody here, but I think a lot of people also want to know what's on the horizon, what are the next steps, not just what's currently standard of care. And so I think that's really kind of the flavor of this presentation, and obviously take questions at the end of the talk, hope that it really addresses some of the thoughts that you all had about where are we going with cancer treatment. So this is my conflicts disclosure slide. I'm a paid consultant for Foundation Medicine and for a small biotech company called Lymph Therapeutics. So I really wanted to start with definitions. There's so much jargon in cancer treatment and medicine, and I think one of the worst areas is the names of our treatments, and not just the names of the drugs, but just the broad categories. So broadly speaking, what is genetic therapy? What does that even mean? Well, the problem is not only what is it, but what are all these other words that are used in most cases synonymously. So targeted therapy, precision oncology, genetically targeted therapy are all terms that are used synonymously, and it's not to confuse patients. It's just there's just so many different strains of thinking about this and people coining their own terms, but they all essentially mean the same thing. And what they mean is that these are treatments that target a particular genetic feature of an individual's prostate cancer. So this cancer has this genetic feature. We sequence the genome of this cancer. We have to know it by looking at that individual patient's cancer. It's not an average. It's not looking from a large study with a lot of people and applying it to you just based on averages. It's actually characterizing your cancer by getting a specimen from a biopsy, collecting it, processing it, extracting the DNA, sequencing the genome of that cancer, looking for which genes are mutated to create a personalized portrait of your cancer's genome. The various ways we do that look at anywhere from 400 to 600 different genes, which we know have known roles in cancer. Some of them are specific to prostate cancer, some of them aren't. And then some of those genes, it's really not very many at this point, it's probably about 20 or 30 of those genes have a natural drug partner that can be used to essentially therapeutically exploit that gene. So the gene causes the cancer, but also creates a vulnerability in the cancer that can be exploited by a particular medication. So that's called precision oncology. That's what that means, okay? Another important term, checkpoint immunotherapy, checkpoint blockade, immunotherapy more generally. Those are any treatments more generally that don't work directly on the cancer cell, but actually work on the immune system. They work to reactivate the immune system. Checkpoints refer to these natural breaks in the body. When we get an infection, what stops the immune system from going haywire? Why doesn't the immune system turn on and never stop, causing unending inflammation and immune activation? That's a question that scientists worked on for 30 or 40 years and couldn't figure out what was stopping the immune system from growing to treat that infection. It turns out that they figured out what that was. There are about 20 genes that get turned on in the immune system to stop themselves. Those are called checkpoints. They block the immune system from going out of control. It turns out that cancer uses those exact same checkpoints to stop the immune system from going on and being active at all. Those checkpoints are now the targets of the newest generation of immunotherapies, which are on basically 50% of every commercial I think that you'll see in prime time. Yervoy, Opdivo, Keytruda. Some of them are very, very effective treatments, and learning how to use them in prostate cancer is still investigational. It's still what we're trying to figure out. Okay, but they've had a lot of success in melanoma and lung cancer and bladder cancer, and we're very aggressively trying to figure out how to properly use them for prostate cancer. What they do is they release the brakes. Okay, the brakes are just down, and the immune system cannot turn on. Those are checkpoint immunotherapies. So what I wanted to tell you about is what genetics and immunotherapy have to do with recurrent prostate cancer. Cancer that has relapsed or come back or recurred after having tried to cure it with surgery or radiation. What happens then? That's called a recurrence or a relapse. Why am I starting with the recurrence and relapse? Why not start from the initial diagnosis? And maybe we should be using genetic therapies and we should be using immunotherapy at the time of original diagnosis, either with radiation or with surgery or instead of radiation or instead of surgery. That would make a lot of sense. And it does make sense, but we're not there yet. Okay? Right now, there are here and there around the country, around the world, there are places that are testing that idea to try to sequence the cancer at the time of initial diagnosis and try to change the initial treatment to combine with surgery or with radiation. But that's a very difficult place to test something new, as you can imagine, because whenever we're designing clinical trials, we're always weighing the promise of the new treatment versus the risk of the new treatment, and we're most careful about that balance in patients that can be cured with surgery or radiation. So patients with early stage prostate cancer that can be cured, we only bring forward the most promising, the safest treatments to test in that area. Right now, that's not a major area or context where we're testing these new ideas. We're testing them in recurrent prostate cancer because recurrent prostate cancer needs better treatments and is not yet curable. Okay, and that's why we're trying to first show that our treatments are very promising, very active in recurrent prostate cancer, and then once we've established that profile of effectiveness and safety, bring the new treatment into the earlier stage. That's the same paradigm that's used in essentially every cancer type and essentially every kind of disease. Okay, so recurrence means when the PSA essentially starts to come back up. And there are different definitions of when that is, depending on whether surgery was the original treatment or whether radiation was the initial treatment. But suffice it to say, that's what we're talking about. Now, how do we treat it? So I'm not going to talk a lot about focal therapy tonight because that's a whole other topic. Dr. Weisach is here too that actually does the focal therapy, so he could be a person to ask questions about. What it generally means is that trying to find that cancer that's recurred and treating it without the use of medications, treating it with some type of laser-targeted, focused treatment with either radiation or cryotherapy, freezing it, okay, or using high-frequency ultrasound to raise the temperature to burn it, okay? Or to take it out. Those are all focal therapies. I would just call it that generically because it's not using a medication that goes everywhere, right? It's just going to the cancer that we found. I'm going to talk more about systemic therapies. Now, when do we think about And systemic therapies are any kind of medication. It goes everywhere. So immunotherapies, checkpoint immunotherapies, targeted therapies, all these kinds of treatments, those go everywhere. When do we think about it? Well, we think about it.
So I would speak up a little
Oh,
bit.
absolutely, absolutely.
Thanks.
We think about it when we think that the cancer is systemic, where there's good reason to believe that it's not just in one spot. And we usually think about the cancer as being systemic when the PSA recurs very quickly after a surgery or radiation, suggesting that taking out that prostate or treating that prostate just didn't do very much, probably because there were cells microscopically that were somewhere else already from the beginning. Okay, so that's a systemic problem. When we think about a focal problem where the cancer is just in one place, when a person's had a surgery or radiation and several years later the PSA just starts to come back up, suggesting that maybe that cancer was taken out, the major part of it, but maybe some cells are still just in one area and having a hard time to grow in that one area. Okay, so where is the recurrence? Well, the most common areas are what we think about are typically locally, so right near where the prostate was, in that area that I don't know how God figured out to make a prostate in that area, but God, that was not a great place to make it, right? But smack dab between the rectum and the bladder with erectile nerves surrounding it. Wow, I don't know if I would have thought about that. So that could be the area, okay, which is very common in certain circumstances. But if it's spread, if it's recurred and spread, then where does it spread to? Generally speaking, those little green dots there, those are lymph nodes, okay, or the bone, okay? Those are the most common areas where prostate cancer will recur. What are those green dots? What are lymph nodes? So sometimes you'll see in a scan report, the lymph nodes are there, they're 0.6 centimeter. What is that? Lymph nodes are normal, and they're your swollen glands. When you had strep throat as a kid, they're in your neck. Every organ in the body has a set of draining lymph nodes where the immune system hangs out to monitor surveillance for infection. Okay, it drains every part of the body, including the prostate has draining lymph nodes, which are typically in that area, right around the prostate in the pelvis. So cancer cells can drain into those same areas, and that's a way for them to essentially hijack themselves on a highway and get out, and that's what they use. When those lymph nodes grow, that's because the cancer cells are growing in them, and so we don't. What we typically look at is the architecture of the lymph node and the size of the lymph node to decide, is that lymph node occupied by cancer cells or not. Suffice it to say, that's where we typically see it. But when we're talking about systemic therapy, treatments that go everywhere, we're a little bit less concerned with the particular lymph nodes that are involved, the particular areas of bone. We're a little more concerned with just the fact that this is systemic and that a medication that goes everywhere is going to be the best option. Almost all of our medications, and we'll talk about some that are the exception, almost all of our medications will treat cancer, whether they're in the cancer cells are in the lymph nodes, in the bone, in the liver, in the lung, or still in the prostate area. And that's why systemic therapy is typically used for this very common circumstance. So if we're going to talk about systemic therapy and prostate cancer, we're going to have to just do a very basic primer on testosterone and prostate cancer and how our hormonal treatments actually work, because hormonal therapy is still the most effective, most predictably effective treatment for as a first treatment for recurrent systemic prostate cancer. So what is testosterone? What is the relationship between testosterone and prostate cancer? Well, it's a fuel. So it's a fuel for the fire of the cancer cell growth. So testosterone is one of the male hormones. There are others, okay, but testosterone and its derivatives are the major male hormones produced in the majority of in the body, in the testicles. Okay, that's where most of the testosterone and the male hormone derivatives of testosterone, one of them is dihydrotestosterone, are synthesized. The testicles are actually behaving only in response to the brain. The brain secretes a chemical called LH, which tells the testicle to produce testosterone. It won't happen on its own. So, for example, and actually that LH secretion by the brain is very responsive to the levels of testosterone in the blood. And that's called a negative feedback loop. When testosterone is made, if too much of it is made, right, then the brain senses that and shuts off LH. And it's almost like a thermostat that keeps the testosterone at a normal level. For example, bodybuilders, or I guess home run hitters for the last 25 years, who are taking testosterone and its derivatives, they actually have very small testicles, okay? Because they're increasing the levels of their testosterone dramatically, which is telling the brain, hey, there's way too much testosterone around, which actually shuts down LH, which then shuts down the testicle production of testosterone, which is the major role for the testicles, okay? And they actually shrink, okay? So that's a bit about how that all works, okay? Now, how does our major treatments, Lupron, Firmagon, these are the major treatments, the other names, Leuprolide, Degaralex, for these types of treatments, what do? They actually tell the brain to shut off the production of LH. So they in doing so, again, stop that message that gets to the testicles to produce testosterone, and that shuts down that part of this. Now I'm drawing the adrenal gland there. Has anybody heard of the adrenal glands? It's sort of an arcane gland. They're right on top of the kidneys, and they also produce lots of hormones. One of them, the hormones they produce, is another source of male hormones, okay, called androstenedione, DHEA. Those are other male hormones that can stimulate prostate cancer growth as well. And that's going to come up later because our newer treatments, one of them is called Zytiga, works by shutting down the adrenal gland production of the male hormones, which can be an accessory supply of male hormones to fuel the prostate cancer, which won't be affected by the brain's production of LH, because LH does not speak to the adrenal gland, only speaks to the testicle. So now, immunotherapy, sort of just a bit of background on that, just to get the first principles here. Diving into the details, some questions would be great, but I think it's important to get kind of the first principles of how we think about systemic therapy. So, immunotherapy and cancer and the immune system. There is a spectrum in human cancer, whether it's prostate cancer or other types of cancer, where the cells, there's a spectrum of how foreign those cells look to the body. Okay? There are some cancers that look very similar to the body, to the immune system, to a normal cell. Now, there's a spectrum there. The more foreign that cell looks, the more likely the immune system is actually able to detect it. Okay? Now, what makes a cell more foreign to the immune system? Why would it look foreign? It's part of your body. It's a human cell. What does that even mean? So we understand some of this. We don't understand at all why the immune system works on some cancers and not on others. One of the things we understand is that as the DNA of a cancer, as the genome is more and more messed up, as it's more and more mutated, that makes that cancer cell look more and more foreign, almost like another kind of cell, like a bacteria or a virus, which the immune system is very, very good at detecting and dealing with. The more mutations a cancer has, the more foreign it looks to the body. The more likely the immune system is able to detect it and potentially kill it. Okay? Now, prostate cancer is not, for the most part, prostate cancer is not very foreign. But here's where personalized medicine, precision medicine matters, because every person is different here. Every cancer is different, and there are patients with prostate cancer whose cancers actually do look extremely foreign and potentially already would be candidates for immunotherapy. And I'll show you some of that right now. So this was actually a game changer. It changed how we think about cancer treatment. This came out about a couple years ago, which basically made this point. What they did is they found the patients that had this very foreign looking cancer, and it wasn't specific to prostate. It actually wasn't specific to any kind of cancer. It was there. Most of these cancers are colon cancers, but this study was done using a treatment called Keytruda that I talked to you about before, a checkpoint immunotherapy, which found and this study did precision medicine, so it looked at the genetic sequence of every patient's cancer and included patients on the study if they had this type of genetic feature, which is a high mutation rate. Lots of mutations equals very foreign, right? And what they found was a quite dramatic response. Okay, and so I'll tell you what I mean by that. So what they did in this study was they did genetic sequencing of cancers, including prostate cancers, to detect this high level of mutation rate called microsatellite instability, which just means a lot of mutations. And what they found is that those cancers were, even though those patients had tried and failed other therapies and therefore had very aggressive disease, a high percentage of those cancers shrank, okay, with immunotherapy, and those responses tended to be durable. Those responses, this is only 2 years ago, so we don't have a lot of follow-up data, but the responses were in the years range. Interestingly, the response rate was only 50%. I'd like it to be 100%, but it was only 50% of those cancers shrank. The others did not. But those cancers were essentially refractory to any other treatment. And so this was a new option for those patients who were on that study. What we've now found is that it's possible to even augment that effect to up to an 80% response rate by combining with other immunotherapies. Okay, now the interesting thing is that the FDA looked at that study, which by the way only had 6 patients with prostate cancer. It's a very small study for each individual cancer type, but the total study had about 60 or 70 patients. And the FDA, which is actually quite forward-thinking right now about how they're doing things, and some people think a little bit too aggressive, but the FDA looked at that and said, we're going to give FDA approval to Keytruda, that immunotherapy, for any cancer type that satisfies this precondition of having a very high mutational load. So lots of mutations is already a standard of care at this point for any cancer type, including prostate cancer. So the other elements that have really changed our treatment is Zytiga. So I told you about the adrenal gland and that accessory production of hormones that can come out of the adrenal gland. Well, abiraterone, which you see in the title of these 2 very important studies, which is the generic name for Zytiga. Zytiga, by lowering the levels of those accessory hormones from the adrenal gland, can dramatically improve the response to hormonal therapy in recurrent metastatic prostate cancer. So prostate cancer that's recurred, is systemic, needs treatment with hormones. In many men, the best thing to do is no longer just hormones, just lowering of testosterone with Lupron or Firmagon like I showed you. The best thing is actually to augment that effect by getting rid of all of that fuel, not just some of it. And that, I think in hindsight, that makes a lot of sense. But it took a long time to figure out that that's where those other hormones were coming from. Okay, so that's the Zytiga here, or abiraterone, Abi here. You see that it's blocking the adrenal gland. It's therefore blocking the rest of the fuel that promotes the growth of that prostate cancer. Abiraterone is not, or Zytiga is not benign. It clearly has some side effects. Did cause some blood pressure problems in about 15% of patients. Did cause some electrolyte problems, some liver irritation in a minority of men, and some cardiac problems, which is obviously very serious, but only 3% of men. So when we're weighing the risks and benefits, every patient has a different, unique cardiac or cardiovascular profile, and so that needs to be weighed. But in the majority of men, adding Zytiga on in context of recurrence is a good idea because it's actually been shown to dramatically improve the response. So what is the response to hormones? How often do hormones work in that context? It's actually nearly 100%. Okay, it's probably the most predictable treatment that we have in all of cancer, because there are very few other cancer treatments that nearly work 100% of the time. The problem is that how long will it work for? How soon will the cancer become hormone resistant? And that's what's variable. That can be as short as 6 months. It can be as long as 3 or 4 years. On average, it's about 1.5 to 2 years. In the patients that were treated with Zytiga, in addition to the hormones, in that context, it delayed the recurrence of the cancer. It put the cancer to sleep for a significantly longer period of time. On average, I told you about 2 years with the hormones alone. Adding the Zytiga put the cancer to sleep on average about 4.5 years. Okay, so again, we have something that works a lot better than that, but at least we're getting extra years with actual, life-altering or quality-of-life altering side effects in addition that added on by the Zytiga are actually not that bad. This is not chemotherapy. This is not going to cause major fatigue or major significant side effects that alter our patient's quality of life. So chemotherapy, where is the role? There still is a role for chemotherapy in prostate cancer, although thankfully other treatments are coming along, like I've talked to you about, and are replacing chemotherapy in some patients. But thankfully the chemotherapy that we use for prostate cancer is one of the milder chemotherapies that's used for our patients. It's actually the one on the bottom. It's called Docetaxel. The brand name that people know it by is Taxotere. It's approved actually in 2004, shown to be effective in 2004 at the same time, and is used for patients both with hormone resistant, but actually in that same hormone sensitive context. I'll tell you that context, that decision point is really very important. The first evidence of recurrence, what are we going to do? We have more and more options now, and the decision is actually more and more complicated about what to do in addition to hormones. Do we do hormones alone, Lupron alone to lower testosterone, or do we add on Zytiga to augment the effects like I told you about, or do we look at this study, which also is relatively recent from 2015, which showed that adding chemotherapy in that context is also very effective. It's become a very complicated landscape. More studies are now comparing chemotherapy and Zytiga, and thankfully, in my opinion, those studies are actually showing that the Zytiga is even a bit more effective than chemotherapy. So in most patients, the Zytiga, which in my experience is a better tolerated approach than chemotherapy, is being used in that initial context of the systemic recurrence. Chemotherapy, as you'd expect, will lower the blood counts, and so can increase the risk of infection, although thankfully the risk of severe infection is quite low with this chemotherapy. Severe fatigue, not very common, but some moderate fatigue is relatively common, and that's why we really think about it very carefully before pulling the trigger on chemotherapy. So let's talk a little bit about where we are with what's new, and I think and answer some questions. So I want to talk a little bit about this element here, BRCA1 and BRCA2. This is a bit of a busy slide. BRCA1, what are those? BRCA1 and BRCA2, we know that we've heard about them in the news over the last few years. There are celebrities that are born with this gene, like Angelina Jolie, and bilateral mastectomy to prevent breast cancer. This gene in women causes breast cancer and ovarian cancer at a very high frequency. Up to 80% of women born with this gene will develop breast or ovarian cancer. It's shocking, but that one gene can do it, okay? It turns out the same gene causes prostate cancer in men, okay? And that's only really come to light in the last couple of years. At this point, because of that, we're not only treating the patient, but we're treating the patient's family. We want to be sure that if there are female relatives, daughters, sisters, that we're making sure we're not missing this. So in any patient with metastatic prostate cancer, cancer that has recurred and spread, we're testing for the presence of this gene here, and in many academic centers as well. In the community, this is not really filtered down yet, but we're trying to spread the word. through social media, actually, because this is a very important thing. It's only about 10%, thankfully. It's not a very high frequency in our patients, but 10% is still a significant number in our opinion, because it has major implications for family members. Now, it also potentially has major implications for treatment. So, and I'll show you why. There's a new class of drugs called PARP inhibitors, which were developed. That's an example of a precision medicine, because PARP inhibitors, these drugs, and some of which are FDA approved already for breast and ovarian cancer, they're specifically developed to work for cancers with this genetic feature. So it's another example of a specific genetic feature. The other one I told you about was high mutation rate, right? That can be whose partner would be immunotherapy. Here, the genetic feature is BRCA1 or BRCA2 that would partner with PARP inhibitors. There's actually several of them out there, so it's not worth going into particulars. But that's another reason why we like to sequence our patients' cancers so that we know what the genetic portrait is of that person's cancer, to individualize therapy. And there's some already good data that they're very active in prostate cancer. So in this study, which really kind of turned the field and made everybody pay close attention to what's going on, close to 80% of patients who had that genetic features, when they were treated with this kind of PARP inhibitor, their cancer regressed, despite the fact that prior chemotherapy hadn't worked for them, prior Zytiga had stopped working for them. So this is potentially a very exciting option. Okay, so I know we're running a little bit short on time. I wanted to just touch on two things that are not even yet in kind of the public limelight, but I think are probably two of the more promising approaches that we're now testing in the investigational. So what are the new exciting drugs? This is one of them. We actually have this trial here at NYU. We're one of the few international sites that has this. So this is a new gene called EZH2. Okay, I don't know where they come up with these names. Sorry. But it's a new gene called EZH2 that is involved in a very interesting cellular process called epigenetics. This is a kind of a new frontier in science where we now understand that the genes of any cell can be manipulated without them actually being fundamentally changed or mutated. It's almost like Lamarckism in a way, versus Darwinism. So it turns out that our environment actually does dramatically change our genes, and that could be heritable. There is some really interesting studies about that. That if you look at the grandchildren even of Holocaust victims, that you could see changes in their genes based on the concentration camp experience of their grandparents. It's quite shocking, actually, how this works. But this gene, how does that filter to prostate cancer? Well, it turns out some of these epigenetic changes can turn the genome into a cancer-promoting genome. And we now understand some of actually how that works. And we now have a treatment that will leverage that understanding and exploit that. For example, this treatment that blocks this gene called EZH2 can actually shut off testosterone fueling without affecting testosterone levels at all, but shut it off in the cancer cell. So it's almost science fiction how these things work, but it's actually a very exciting new approach where we're already seeing some reasonable evidence that there is anti-cancer activity there. So that's very exciting. That trial is actually now open at NYU, and we're looking forward to the results. The final one is a trial that is scheduled to be open in the next month or two at NYU. It's actually based on research that I did to discover this gene as another potential gene that is causing a type of prostate cancer. So the gene is called DKK1, and what we know about DKK1 is that it's turned on in a subset of prostate cancers. Again, unfortunately, this is not a one-size-fits-all. That's where a lot of this field is heading. It's trying to characterize an individual patient's cancer and treat them in a particular way. And that's a double-edged sword, right? Because it would be a lot easier to just find something that works for everybody, and hopefully we'll find that. But in the meantime, we're finding things that are maybe relevant for 20, 30% of patients, And so we have to look and do a little bit of work on the front end to see if it applies to that individual. So a subset of these cancers turn on DKK1, which is a gene that's linked to poor prognosis of cancer, in prostate cancer specifically. The good thing is that we think we can actually measure this gene in the blood. So we may not need a biopsy always to see if it's there. It's another one of these buzzwords you may have read in the media, liquid biopsy. So to get at the cancer, biopsy it without actually doing the biopsy. Actually first pioneered by obstetricians, right? Because nowadays many women in early stages of pregnancy don't need an amniocentesis anymore. They don't need a needle going through the amniotic sac into the fetus, right, to get a tissue sample. Nowadays, all you do is a simple blood test, because you could pick up low levels of that fetus's chromosomes that spilled into the mother's blood. Right? So that same technology is what we're trying to use for cancer, to pick up low levels of the cancer's aberrant, weird DNA circulating in the blood. That's sort of what we're trying to do here with DKK1 as well. We think DKK1 is actually being spit out by the cancer, again, to turn off the immune system around it, create sort of a shield around it, and that we have a nice new drug that we see is very well tolerated, that can turn that signal off. And so we're going to see what it does. We're obviously optimistic and hopeful, but we actually need to try it. And so that trial is going to be open here, again, for recurrent prostate cancer, not early stage, because it's too experimental, but it's well tolerated, and we're going to try it as a promising option for patients who've already had Zytiga. Okay, so again, that's the context where we're going to test it. Listen, I'm going to leave things there because there's just too much to go through, but take some questions. I appreciate your attention. Thank you.